Welcome to this Step 2 clinical knowledge tutorial on urinary tract disorders. This session is designed to help you master the high-yield concepts and test-taking strategies you need for board exams. We'll walk through case-based questions covering UTIs, pyelonephritis, kidney stones, urinary retention, and hematuria workup. The focus is on pattern recognition and applying clinical reasoning to multiple-choice questions. Remember, boards test your ability to recognize classic presentations and choose the most appropriate next step. Today we have 3 main learning objectives. First, we'll focus on recognizing the classic question stems that signal specific urinary tract conditions. Boards love to use certain buzzwords, and knowing these patterns gives you a significant advantage. Second, we'll practice distinguishing between upper and lower urinary tract pathology. This distinction is critical because it completely changes your management approach. Third, we'll review the systematic approach to hematuria and urinary retention, which are commonly tested topics. This tutorial assumes you've reviewed the foundational nephrology and urology content. We're here to apply that knowledge to questions. Before diving into cases, let's establish the framework you should use for every urinary tract question. The first question to ask, is this upper tract or lower tract? Lower tract means cystitis. Look for dysuria, frequency, urgency, and suprapubic pain without fever. Upper tract means pyelonephritis. Look for flank pain, CVA tenderness, fever, and systemic symptoms. The key teaching point: fever plus flank pain equals pyelonephritis until proven otherwise. The second question: is this complicated or uncomplicated? Uncomplicated means a young, healthy, non-pregnant female. Complicated includes males, pregnant women, diabetics, immunocompromised patients, catheterized patients, or anyone with anatomic abnormalities. Why does this matter? Any complicating factor changes your antibiotic choice and duration. Let's review the high-yield buzzword associations that boards love to test. For UTI, the classic combination is dysuria plus frequency plus pyuria plus bacteriuria. When you see this pattern in a young, healthy woman, think uncomplicated cystitis. For nephrolithiasis, look for colicky flank pain radiating to the groin combined with hematuria. The word colicky is key. It means intermittent, cramping pain that comes in waves. For urinary retention, the typical patient is an older male with suprapubic fullness and inability to void. Often there's a precipitating factor like a new medication. Train yourself to recognize these patterns quickly. It will save you time on the exam. Here's our first case. Take a moment to read through it and think about your answer before we discuss it. Key details to notice: 24-year-old sexually active woman, 2 days of symptoms, burning on urination, frequency, suprapubic discomfort. She denies fever, vaginal discharge, or flank pain. Vitals are normal. UA shows pyuria and bacteriuria. What's your differential? What would you do first? The question asks for the most appropriate next step in management. Let's walk through this case systematically. Analyze the stem clues. This is a textbook lower UTI. Dysuria, frequency, suprapubic pain, the classic triad. No fever rules out systemic infection. No flank pain rules out pyelonephritis. The urinalysis confirms infection. Identify uncomplicated criteria. She's young, healthy, female, and not pregnant. No mention of diabetes, immunosuppression, catheter, or anatomic issues. Answer analysis. Option A suggests getting a urine culture first, but this delays treatment unnecessarily. In uncomplicated cystitis, empiric treatment is standard. Option B is correct. Nitrofurantoin for 5 days is first line for uncomplicated cystitis. Option C suggests CT imaging, which is not indicated for simple lower tract infection. Option D suggests IV antibiotics and admission, which is way over treatment. The correct answer is B. Here's case 2. Notice how the presentation differs from case 1. Key details: 32-year-old woman, 3 days of dysuria and frequency, so she started like a UTI, but now has fever to 39 degrees C, nausea, and severe right flank pain. She has CVA tenderness on exam. UA shows WBC casts. This case illustrates the progression from lower to upper tract infection and tests whether you can recognize the upgrade in severity. Think about your answer before we discuss. Let's analyze this pyelonephritis case. Recognize upper tract involvement. The triad of fever, flank pain, and CVA tenderness equals pyelonephritis. The presence of WBC casts is pathognomonic for kidney parenchymal involvement. This is a high-yield fact. Systemic symptoms like nausea indicate tissue invasion. Test strategy. Any systemic symptom should make you upgrade from cystitis to pyelonephritis. Answer analysis. Options A and B are wrong because nitrofurantoin and fosfomycin don't achieve adequate levels in kidney tissue. They concentrate in the bladder. Option C is correct because fluoroquinolones penetrate renal tissue well and are first line for outpatient pyelonephritis. Option D is wrong because 3 days is too short for upper tract infection. The correct answer is C, oral fluoroquinolone for 7 days. Here are some key management pearls to remember. For uncomplicated cystitis, you have 3 first-line options: nitrofurantoin for 5 days, TMP-SMX for 3 days, or fosfomycin single dose. Boards may test you on why fluoroquinolones aren't first-line for simple cystitis. It's to preserve them for more serious infections. For pyelonephritis, outpatient treatment is a fluoroquinolone for 7 days. If the patient is septic, toxic appearing, or can't tolerate oral intake, they need IV antibiotics and admission. When do you need imaging? If there's no improvement in 48 to 72 hours, if pyelonephritis keeps recurring, if you suspect abscess or obstruction. CT with contrast is preferred. Boards love to test when imaging is and isn't indicated. Know both scenarios. Case 3 presents a completely different picture. Key details: 45-year-old man, sudden onset, severe left flank pain radiating to groin, writhing in pain and can't get comfortable, nausea but no fever, UA shows hematuria without pyuria. Several classic features here: the radiation pattern, the patient's inability to find a comfortable position, and the urinalysis findings. The question asks for the best initial diagnostic test. Think about your answer. Let's break down this nephrolithiasis case. Classic presentation clues. Colicky flank pain radiating to the groin is pathognomonic for a ureteral stone. The fact that he's writhing and can't get comfortable is a key differentiator. Peritonitis patients lie perfectly still. Hematuria without pyuria supports stone over infection. Test strategy. Pain pattern and patient position are key differentiators. Answer analysis. KUB X-ray misses radiolucent stones like uric acid stones. That's why A is wrong. Non-contrast CT is the gold standard because it detects all stone types and shows hydronephrosis. B is correct. IVP is outdated and requires contrast. C is wrong. Ultrasound is second line and may miss ureteral stones. D is wrong. The correct answer is B, non-contrast CT of abdomen and pelvis. Case 4 shifts to urinary retention. Key details: 70-year-old man with BPH, can't urinate for 12 hours, severe suprapubic pain, recently started diphenhydramine, exam shows palpable tender bladder. Multiple clues here: the underlying condition, BPH, the precipitating medication, the time course, and the physical exam findings. What's the most appropriate initial step? Think through your options. Let's walk through this acute urinary retention case. Identify the precipitant. BPH is the underlying cause, but diphenhydramine, an anticholinergic, is what pushed him over the edge. Board questions love to include medication triggers. Antihistamines, decongestants, and anticholinergics are common culprits. Assess the urgency. Palpable bladder plus inability to void equals acute retention emergency. The suprapubic pain tells you the bladder is distended. There's risk of post-obstructive kidney injury if this isn't addressed quickly. Answer analysis. Imaging delays decompression. A is wrong. Alpha blockers take days to work, and this is an emergency. B is wrong. Immediate bladder decompression via catheter is the priority. C is correct. Cystoscopy isn't needed acutely. D is wrong. The correct answer is C. Place urethral catheter immediately. Case 5 is critical for boards. Painless hematuria. Key details: 62-year-old man, 40-pack-year smoking history, painless gross hematuria, denies dysuria, frequency, or flank pain. UA confirms blood but no infection. The combination of age, smoking history, and painless hematuria should immediately raise a red flag. What's the most appropriate next step in evaluation? Let's analyze this Hematuria Workup case. Red flags for malignancy. Painless gross hematuria is bladder cancer until proven otherwise. This is a must-know concept. Smoking is the #1 risk factor for bladder cancer. Age over 50 significantly increases suspicion. Test strategy, painless, plus smoking history, plus older age and immediate full workup. Answer analysis. Waiting to repeat UA risks missing malignancy. A is wrong. Cytology alone has poor sensitivity, around 40%. B is wrong. Full workup requires both cystoscopy to visualize the bladder and CT urography to evaluate the upper tracts. C is correct. There are no signs of infection, so empiric antibiotics make no sense. D is wrong. The correct answer is C, cystoscopy plus CT urography. Here's a practice question for you to work through on your own. Key details: 28-year-old pregnant woman at 16 weeks gestation, dysuria and frequency. UA shows pyuria and bacteriuria, a febrile with no flank pain. This tests whether you recognize pregnancy as a complicating factor and know the treatment considerations for UTI in pregnancy. Think through your answer. Consider, is this upper or lower tract? Is this complicated or uncomplicated? What are the safe antibiotic options in pregnancy? The correct answer is D, fosfomycin single dose followed by urine culture. In pregnancy, you always treat bacteriuria, even asymptomatic, and you need a test of cure. Fluoroquinolones are contraindicated in pregnancy. Nitrofurantoin is safe in the second trimester, but requires 5-day course. Fosfomycin offers effective single-dose treatment with good safety profile. Thank you for working through these cases with me. For continued learning, make sure to review the nephrology and urology sections of your primary board review resources. Focus especially on UTI treatment algorithms, nephrolithiasis management, and hematuria workup protocols. Then practice with question banks to reinforce these concepts. If you want one-on-one tutoring or residency advising, visit roadmap2residency.com. Remember, pattern recognition is key. Know your buzzwords, know your management algorithms, and practice applying them to questions. Good luck on your exam.